Hello everyone, I'm Yusuf Muharram, this is MedSense, and now we're gonna talk about ECG. ECG, or the electrocardiogram. This name means the recording of the electrical activity of the heart. Actually, the electrical activity of the heart is so unique. To understand this, let's take a closer look inside the heart. What is so unique about the heart when it comes to electricity or the electrical activity is that heart generates its own electrical impulses. It starts from here, from the SA node. It sends the electrical impulses or the positive electrical current, or in other way, the depolarizing action potential to the both atria, and the major of this electrical impulse goes to AV node to be transmitted down to the both ventricles. But actually, AV node delays this electrical transmission. It holds on this positive electrical current or this depolarizing action potential for about 0.1 to 0.2 seconds. Then it releases this electrical current down through the bundle of Hess, then through the right and left bundle branches. Then through the Purkinje fibers, this positive electrical current is transmitted to the rest of ventricular cardiac myocytes in both ventricles, the left and the right. We have to emphasize on certain thing, that the left ventricle is more muscular than the right. It's bulkier than right ventricle. So we can predict that left bundle branch is thicker than the right. Now, as we know the electrical current pathway, let's interpret this into ECG. To do this, let's imagine that you are an ECG electrode, ECG positive electrode actually, and you are located right here. You are looking at the heart, and this positive electrode can detect any positive electrical current when it is moving or propagating on its way as positive deflection. And when this positive electrical current is moving or propagating away from this positive electrode, it will interpret it as negative or down deflection. Okay, let's do it again. Our electrical impulse started from SA node. It transmitted to both atria, and the major electrical output goes down there to AV node. Now we have positive electrical current moving this way. This positive ECG electrode interpreting this positive electrical current, which is moving on its way or towards it, as positive deflection. We call it P wave. So, P wave resembles the depolarization of both atria, and of course, the electrical current from SA node to AV node. On AV node, the electrical current poses already knew that AV node is a bit procrastinator, and it holds on this positive electrical current for some time. As we said, it is about 0.1 to 0.2 seconds. This positive ECG electrode detects nothing because there is no electricity flowing, there is no electrical current at this time. So it is just flat line, no positive, no negative deflections, because there is no electricity flowing either ways. Then AV node release this electrical impulse down to the ventricles through bundle of Hess, then right and left bundle branches. And as we said, that left ventricle is more muscular and more bulkier than the right ventricle. So we can predict that left bundle branch has to be thicker because it has to carry larger electrical current. So now through bundle of Hess and right and left bundle branches, we have to excite or to depolarize the interventricular septum, from where the interventricular septum takes the majority of these electrical impulse from the left bundle branch because it has much more electrical current than the right. So the electrical impulses is going this way from left bundle to the rest of interventricular septum thickness. Of course, the right bundle branch shares to depolarize the interventricular septum, but this is the net vector from left to right, this way. Okay, back to this. You, as a positive ECG electrode, seeing this electrical current. Is this in your way or away from you? Actually, it is away from you. So this positive ECG electrode will interpret this as negative deflection because it is a positive electrical current going or propagating away from it. So it will be a slightly negative deflection and we call it Q wave. Then from here, through the both bundle branches and then Purkinje fibers, the electrical current or the positively charged depolarizing electricity or electric current is going down there to stimulate the cardiac apex. And as we said before, because the left ventricle is more bulkier and muscular than the right, then the net vector of this electricity is going this way. Of course, there is some going this way, but this is much more. So the net vector of the electricity is going this way. What about this positive ECG electrode? Seeing all this electrical power pointing toward it, it will interpret it as a spiky positive deflection. We call it R wave. Okay. Then, through Purkinje fibers, the electrical impulses, the positive electrical current, is propagating through the both ventricular myocytes toward the cardiac base. This way on both ventricles. So again, what about this positive electrode of ECG? Seeing this positive electrical current moving away from it, it will interpret it as negative deflection. Like this, we call it S wave. Now, the heart, the cardiac myocytes are excited, are positively charged because these positive electrical impulse and positive depolarization, it is now positively charged. It stays there or being stuck there for some time to reorganize its electrolytes and to back again to the negative polarized or resting state. When the cardiac myocytes are resting, it is negatively charged. We call it the resting or polarized state. But to move from the positive, excited state to the negative state, it takes some time. Through this time, there is no electrical current. There is no electricity is flowing either way again. So, ECG electrode will interpret it as a flat line. We have to know something about this. It has to be isoelectric. Isoelectric means there is no positive deflection or negative deflection. So we have this flat isoelectric line. After some time, the ventricular myocytes start to change its charge, its electrical charge, from positive, depolarized, excited state to the resting, negatively charged state. This negative current propagating this way. And try to think about this. We have here a positive electrode. It was interpreting any positive electrical current when it is flowing towards it as positive deflection. Now we have two opposites. We have negatively current instead of positive electric current, and it is moving away from it instead of moving towards it. So now we have negative electrical current moving this way, so away from this electrode, and because of these two opposites, we have negative electric current and it is moving the opposite way. ECG will interpret this as positive or upward deflection. We call it T wave. So let's recap this really quickly. ECG waves, P wave, QRS, T waves. P waves resembles the depolarization of both atria and of course the electrical impulse moving or transmitting from SA node to AV node. Q wave, the depolarization or the excitement of interventricular septum. R wave, the depolarization of cardiac apex. S wave, when these electrical impulses are propagating toward the cardiac base. Then we have ST segment. We have to give a real attention to it. It has to be isoelectric, not above, not below the baseline. Then T wave, which resembles the repolarization of ventricular myocytes. ECG waves are printed on papers like this, with these large boxes and small squares. The x-axis resembles time or the duration for each wave. The y-axis is the amplitude or voltage for each electrical impulse. We have to know that each large square resembles a duration of 0.2 seconds, and each small square is about 0.04 seconds. Important durations to know that PR interval has to be within 0.1 to 0.2 seconds. So it doesn't have to exceed one large box. Why do we have to know the PR interval duration? We have to know it to know the time it takes for AV node to transmit the electrical current from atria to ventricles. PR interval are the interval between atrial depolarization and the start or beginning of ventricular depolarization. QRS complex duration doesn't have to exceed 0.1 second, or in the ECG squares, it ranges between 3 to 5 small boxes. Now we are done with ECG basis. Hope it makes more sense than before. In the next video, we will learn how to read a normal ECG. Make sure you subscribe, activate the bell button to be notified for the next MedSense specials and MedSense videos. This is MedSense Specials. I'm Yusuf Muharram. Thanks for watching.